We look at embryos in the in vitro lab all the time, and we're constantly fertilizing eggs and creating embryos from which we choose the best of the best for placement. And in fact, more and more of our families are using single embryo transfer, which means that if there are 10 or 12 embryos and they all look great, we still have to make a choice of which one, in many cases, to put in.
We are trying to assess the health and genetic status of embryos before we even transfer them to the uterus of the woman or the surrogate. What this means is after the embryos are created, so the eggs and the sperm come together, we grow the embryos in the laboratory, and we have a few different options for testing embryos. Some embryos can be tested on day 3 of development, and more recently there's been a bigger push to test embryos on day 5 of development at the blastocyst stage.
Implantation genetic screening, PGS, or pre-implantation genetic diagnosis, PGD, are similar techniques that use the biopsy of an embryo to actually take the DNA from the nucleus of its cell and analyze it for whatever it is we might be looking for. Now, there's different reasons to do PGS or PGD. One is to just simply make sure that an embryo that looks perfect, as they often do on the outside, has in fact the essential, completely normal complement of chromosomes, so that when that embryo is implanted and takes hold, the baby is going to be, of course, completely normal. So just making sure that the chromosomes are lined up perfectly will prevent babies being born with some conditions like Down syndrome or other chromosomal abnormalities.
Probably more commonly, genetic testing of embryos is used to look at the chromosome status of the embryos. So it's not about looking for a gene like cystic fibrosis, but it's making sure that the embryos have the right number of chromosomes. We know that if an embryo has an extra or missing chromosome, the likelihood of miscarriage is incredibly high. Most pregnancies that have abnormal chromosomes either don't implant successfully or would miscarry early in pregnancy.
Some families elect to look at the gender information that's related to the chromosomal findings and use the knowledge of whether each or every embryo is a male or a female and transfer that embryo accordingly. For some people, this is not controversial, and for others it is, but we leave that choice to you.
If 2 parents are known to be carriers of a genetic condition such as cystic fibrosis, then we can actually create probes, which are little pieces of DNA that would match the parent's DNA change for cystic fibrosis, and then we can test the embryos to see which of the embryos would be affected with cystic fibrosis, which would be carriers, and which would not be carriers of the gene, and therefore we could make a decision to transfer embryos that were not affected with the genetic condition.
When we first started biopsying embryos for the purpose of testing them 10, 15 years ago, we didn't have the technology that we have today. We had good technology, but it required early biopsy on the 2nd or 3rd day in the IVF laboratory when an embryo might only be 6 cells or 8 cells at the most. What's really, really great now about PGS, pre-implantation genetic screening, is that we have the capability of doing blastocyst biopsy. A blastocyst is an embryo that's 5 days old. The fetal section of the embryo, the inner cell mass of fetal cells, can be 120 to 140 cells, and the shell around the embryo, which gives rise to the placenta, called the trophectoderm, is actually the part that we biopsy. So with minimal disruption of the entire embryonic structure and without actually touching any of the cells that give rise to the fetus, which give rise to the baby, we're able to still get all of the same results that we have always been looking for, but essentially minimal to no risk.